Hey everybody, this is Morgan. She's going to talk to you about what she does, and Morgan's a former student of mine. So Morgan, I don't want to say too much more because I don't want to take away from your presentation, but thank you so much.
All right. Thanks, Mr. Stirrup. I don't even know how many years I've done this now. I think it's like 5 or 6 years I've done this. But this is the first time online, so bear with me. But we'll get started. So kind of the theme I have going on is not just a nurse. So I'll touch on that. But again, my name is Morgan McMillan. So to start, I used to take this exact class that you guys are taking right now, back when I was in high school. The first year I took it, I was a sophomore, and it was probably, I think it was at like 6:30 or something. We had to be in the building and take this class. So you guys are lucky it's a little bit later and now online, so to speak. But we would sit in this class, and it was like Monday, Wednesday, Friday, and we would have different doctors come and talk to us about what they did. So it was always really interesting. Um, so with that, this was my sophomore year, like I said, that I took it, and we did labs on the weekends. So this is me actually holding a brain for the first time, and I did it several times after that, and I loved going to those. I actually was lucky enough and brought my grandma once to a cadaver lab, and she absolutely loved it. So I adored those. So again, going forward, moving to my senior year, I took this class again. So this time, I was mostly the same doctors, but I loved it so much the first time I decided to take it again. But it was this class that actually changed my total perspective and what I wanted to do in life. And of course, it was, right before we graduated. So it was a big step to change. So what had happened is, I don't know if you guys will see him or not, or if he presents or will do this online, but the Navy SEAL. So the Navy SEAL came and spoke, and he said something to me. So he was, I can't remember if he was in nursing school or was a nurse, but he said, doctors care about the disease while nurses care for the patient. And that statement truly made me start to think about nurses and what nursing is. Before then, I actually wanted to go to school to work with ESPN and do like sports broadcasting. So this was a very big jump to move from that to being interested in nursing. So this is what that class definitely changed the course of my life forever. So this is me with Mr. Stirrup on graduation day. I took several of his math classes, so that was extra special. So once I did that class, I decided to change my major to nursing, so to speak, when I went to college. So I wanted to look up what is a nurse. So the actual definition is a person trained to care for the sick, especially in the hospital. And the real definition is someone who goes above and beyond the call of duty, the first to work and the last to leave, the heart and caring, the heart and of nursing, a unique soul who will pass through your life for a minute and impact it for an eternity, an empowered individual whom you may meet for only a 12-hour period, but who will put you and yours above theirs. And that's what really sold me on it. I realized I didn't have a whole lot of experience in the hospital setting, even myself or with family members at this point. And, this idea was very attractive to me, and I thought I would be a good fit for this. So I decided to start looking at colleges to pursue nursing. So I did end up choosing the University of Northern Colorado. That is up in Greeley. So kind of to go off topic a little bit, but when you're looking for colleges, there's several things you want to look for. So do you like the campus? When you're doing a tour, were people friendly when you walked around? Sometimes, depending on your major, they actually did give you a tour of your department you're going to be in, and you actually get to meet some of the teachers. So, did you vibe with them, so to speak? Did you like the dining hall? Did you like the dorm room? Is it somewhere you can see yourself walking around? So based on those factors, that is why I chose the University of Northern Colorado. It's a beautiful campus, and they are one of the #1 schools in Colorado for nursing to get that. So that was an easy pick for me when I decided to go to the University of Northern Colorado. So one of the first steps of becoming a nurse, and not every nursing program requires this. So it's called a certified nursing assistant. So a CNA, if anyone has heard of that. But CNAs, they tend to work in hospitals or nursing homes, or even work with places where they actually go to that patient's home and help them there. But they help with things like activities of daily living. So such as helping someone shower, get dressed, helping someone eat, drink, take their pills for the day. They help with those types of things. Because let's say if you're really sick, or you get older, or even little kids that are sick, sometimes you can't do those things, and sometimes the parents can't be there 24/7. So those are called activities of daily living, and that is what CNAs help with. They also help the nurse out during the day, so they get vital signs, things like that. So they're also an assistant to the nurse, kind of in the name there. Later on, if you've worked as a CNA before you go to nursing school, people tend to know that. It makes you a better nurse. People sometimes, until they've done it, kind of see CNAs as an easy job, so to speak, and it is not. It's very difficult. Not saying you can't do it, it's hard to, get someone dressed, to feed them, to do these things. And so it ends up making you a better nurse. And people really recognize that when you're at work, if you worked as a CNA or not. It also gives you a better head start. You get used to the verbiage, get used to caring for people, you get better at your skills. So I highly suggest, even if your program that you choose for nursing, if you decide to do this to get your CNA license, and potentially try and work as one, just because it will give you such a better head start, and in the end will make you a better nurse, as I've said. I went to ACC to get mine, and I got it done in 3 months, and there's a lot of programs that even do it in 6 weeks. And this is a good way to know if nursing's for you. If you do work as a CNA and you don't really like it, of course in every job there's things you don't enjoy, but there's also things you do enjoy. So this is a good entry into nursing too, to see if this is a good fit for you. So going through the years, my freshman year of college, so the first 2 years of college, you tend to take prerequisites, and that's pretty much for any major. You take kind of these core courses, so to speak. So like biology, chemistry, psychology, things like that, or your LACs, so like an art class or whatever it is. You also get to have fun. So at most colleges, they have like an outdoor pursuits place, so to speak, and you can go and do these fun things. So this is me actually caving, and then I ended up doing it every year after that. So make sure you find some fun stuff to do in between studying. So kind of, not talking about nursing necessarily, but just college, since you guys are all going to be there soon, if that's a route you choose to take, was my dorm room in the back there. That bed is your home, because on the other side is someone else's, for most setups. So, keep it neat, and you don't realize college is super fun to go to, but at the end of the day, this bed is your home, not even the whole room, not the sink, not the bathroom. You have to share everything. And then also, just to be successful, find your study place that you love to go to. So I found a little coffee shop called Zoe's. It was like a 10-minute walk from campus. And it was somewhere I could get off campus, get a cup of coffee, and I would stay here. I loved it so much. I could stay here for hours, and I would get so many things done. So when you get to college, make your place nice, make your home nice, make that bed nice, and then find that place that's a good fit for you, where you can get your studying done and you're not distracted. So those are my big takeaways for freshman year. So going into sophomore year, this is actually most of the time when you apply for nursing school. So that's actually a picture of me turning in my nursing application, because you've waited so long to do this. And I've made it through most of my prerequisite courses, so those biology classes, chemistry classes, math classes, and so on. So Tina, to talk about nursing programs, they're all different, but at the University of Northern Colorado, at the time I applied, they solely accepted people based on their GPA. You turned in a resume in your application because they do a background check, but you didn't turn in essays or things like that, or take like a skilled test. It was simply just GPA. That has changed a little bit since I graduated from there. So just to give you an example, you really have to work hard, because when you're going to a school that has a great nursing program, of course, there's going to be great students also pursuing the same thing as you, but only so many spots. So you have to take it seriously. If this is something you really want to do, you have to hit the ground running. So for me, I actually ended up getting into the nursing program with a 3.99. I got an A- once, so that's why I didn't have that 4.0. But the cutoff for my nursing class, it was 36 people could get in. That was 3.79, I believe. So that's pretty much all A's, maybe a couple A- or one B with all A's. So you really have to take it seriously. Go to those open office hours that the professors offer. No one's going to check in with you to make sure you do things. You have to take control of that yourself. So that's kind of sophomore year of college. So shortly, a few months after that, I found out I got in. I was super excited. And again, not everybody gets in. So usually class sizes, depending on how many teachers they have, is about 36 to 40 with most nursing programs you go to. But they have different start dates. So it just depends. So junior year, so nursing school, how it works is if you're getting your bachelor's, so you can get like your associates in nursing, you can get an LPN, but with the way hospitals are moving, the best thing you could do to set yourself up for success is get your bachelor's in nursing. So that is a 4-year degree. Associates is 2-year, but most hospitals now are not hiring nurses who have less than a bachelor's degree in nursing. So my biggest thing, if you're thinking about nursing, as nice as it seems to get your LPN and work as one, and then, you know, do an online program to get your bachelor's, just go straight to the bachelor's, get it done with. That's one of the biggest regrets I've heard from people at my workplaces. They wish they would have just gotten their bachelor's right out of the gates. And those terms will kind of sound more familiar to you as you go to college and whatnot, and hear about that. So for nursing, it's about 2 years of prerequisite courses. So again, those are like the math, chemistry, biology courses. And then you have actually 2 years of nursing school. So junior year is when I started, and that is your first semester of nursing school. So with that, what you do is you have like a health assessment class. So you learn how to actually complete a head to toe assessment. So you know, feel pulses, you do eye exams, you look in their ears, mouth, you can, you know, learn how to grade tonsils, you listen to heart, lung, and bowel sounds. You get to learn all of those assessment tools. You learn what's normal and then what's not normal. So you get to practice those. And that's actually my friend Megan. She's my best friend. And that was kind of my assessment buddy, so to speak, because you have to learn on somebody. So you learn on each other. So we became friends very quick. You also take like a history of nursing class where you learn about people like Florence Nightingale and things like that. You also have like a skills lab where you get to learn certain skills. So for instance, you get to learn how to start an IV. So that's like putting a little, if you've ever been to the hospital, they put an IV in and they can put like medicine in it or get blood from it, and it goes in your arm usually. So you learn how to do that, or you learn how to put in a catheter correctly. So catheter is this tube that goes up the urethra. So that's like your where you pee from, goes all the way up to your bladder. And so that's for people that maybe someone just had a hip surgery and they can't get up and walk. Well, they can't keep peeing the bed, so you put in a catheter. And this is so the urine would drain through that catheter and then into a bag. So you learn how to like insert a catheter, so to speak. So you get to learn all these different skills that you have. And then after you do that, kind of towards the end of the semester, you actually get to go to clinical. And that's where you get to practice these skills and see what you're actually learning in class. So this is was the first nurse I had coming into clinical. His name was Pedro. And you got to practice these skills. And I was lucky enough too to also be with my best friend again during these clinicals. So you get to put it to the test. And then you also have a nursing clinical group because you can't all be at the same place. So this was my group of people that we went to clinical with, and you get really close really fast. So that's also a really fun part of nursing school, is you make friends that will last forever. So with that though, you go to clinical, and it's not always the case that you hear about in school or that you learned about. And you have to try things maybe for the first time that's not on a mannequin or a dummy. So the picture on the left there, you know, you do sometimes have to fib a little bit and say, yeah, of course I've done this before, because no one usually wants to be the test run. And then, you know, the baby over there, hold up, that's not what the book said. So often those things happen. So you just go with the flow. And the most you'll learn is in the clinical setting, when you're actually at a hospital or working at a facility. That's when you learn the most. You get the basic and fundamentals of it in class, but then you take that and use that in clinical and kind of base it off of there. But truly, I've learned the most I ever could in clinical setting when I actually got to use my hands and my brain together and work with an actual patient. So moving on to second semester, this is kind of when nursing really gets started. You've already been introduced to it. You kind of know what it's about. So this is me at my med-surg clinical. So your med-surg semester, it stands for medical surgical. So if you've ever heard of like nursing floors at a hospital, they have like a med-surg floor, they have a tele floor, which is for like cardiac patients. They usually have a trauma floor, which is where like patients go after they've had a bad car accident. They have a surgical floor where people go after they have surgery. But in general, this semester is called med-surg because you learn about disease processes and then you learn how to care for them. You learn all the things that will show up wrong, like for blood work for this particular disease, or how symptoms they'll have for this disease, and then how you take care of that, not only with like interventions, such as like putting in a Foley catheter, starting an IV, but also medications. What medication would you give when? So that's a lot of what med-surg is, and it is so much fun. You also get a surgery day where you get to scrub in and go to surgery for the day and watch the surgeon. So it's really, really cool. I do have to share that one of my first surgeries I got to see on my surgical day when I was in the OR, I saw them do a below the knee amputation, and they just sawed this person's leg off and handed it to me. Not everyone gets to say they do that, but a nurse does. So really, really cool opportunities. So let's talk about some examples. So a seizure. So a seizure is kind of like when the brain gets excited. You might have a friend or one of your parents or someone you know may have a problem with seizures, or maybe they just had one. Who knows? So a seizure is like the extra firing of neurons in your brain. And what we usually think of when we hear the word seizure is that someone kind of lays on the ground and then they have these big movements, and they're kind of shaking. So that is called a tonic-clonic seizure. So that means the contracting and the relaxing. So that's why you see them shake on the floor. So you learn terms like this in med-surg. So when you see someone lay on the ground and they're fully kind of moving and slashing, that's called a tonic-clonic seizure. So let's say I am at work, I am in my patient's room, and they all of a sudden have a seizure. They start doing this. What do I do, right? So in nursing school, they go over this. They tell you what the seizure is, and then they tell you what you need to do. So when someone has a seizure, they usually can't breathe, right? Everything's contracted, so they can't breathe. So we want to make sure we can get them oxygen somehow. Sometimes they lose control of their secretions, so their spit, they start foaming at the mouth, if you've ever seen that, or even in a movie. So you have to take care of that. So you're going to get suction and start suctioning up those secretions so they don't, get sick or aspirate that, meaning get it into their lungs. You also want to try and give them medication that will stop the seizure, because if a seizure happens too long, guess what? They're not breathing soon enough, their heart's going to stop. So we have to do that. So we're going to make sure they have an airway and give them oxygen. So you put a mask on, give them oxygen. We want to make sure they control their secretions. So for instance, their spit, we want to make sure they're not just like choking on it and aspirate it into their lungs. And then we also want to give them that medication to ensure that that seizure stops. And that medication usually they use is Ativan. So we're going to need to do all those three things. So I'm going to do 1, 2, and 3. So how do I get help though? I can't do all of those things at once. So there's usually like a button on the wall where you say staff assist, or even call out for help. So I call out for help. I get my other nurses in there that I'm working with. Someone helps, make sure the patient's getting oxygen through that mask. One person is getting the suction set up and suctioning their mouth. And then the last person is giving that medication. And at some point, we have to get the doctor in there, right? Or let them know that this patient's having a seizure. So who are the people that tell the doctor the patient is having a seizure? The nurses do. So we are kind of the eyes and the ears for the doctor, so to speak. That doctor would not know a patient is having a seizure unless it was for the nurse that was there. We are with patients more than any other profession within healthcare. Nurses are by the bedside more than any other profession in healthcare. So we really see everything and are the eyes and ears for the doctor. So med-surg, again, you learn about something like a seizure and then you learn how to care for it. So really cool, especially once you get to the clinical setting and you get to put all this stuff you've learned in action. So next, a Jehovah's Witness. So this was a patient I had. So if any of you have watched Grey's Anatomy or are a fan of that, this will kind of spark your memory. So Jehovah's Witness, so I had a patient, it was a female, and for some reason, she just would not stop bleeding. She was vaginally bleeding and just would not. She had huge clots coming out. It just would not stop, and it was going on for days actually before she was admitted to the hospital. So if someone's bleeding, what is something we would do for them to, I guess, take care of that? So we would give them blood, right? That's a kind of an easy fix. They're losing blood, we give them blood, right? Well, if you've seen Grey's Anatomy, you've learned this, but Jehovah's Witness cannot receive blood products. They would rather die than receive blood product. Part of their religion, it's not I don't judge as a nurse, I just care for people. So I had this patient who was bleeding. We've given her all these different medications to try and stop it, and we couldn't. The only thing that was gonna save this woman's life was if she got a blood transfusion. But she's a Jehovah's Witness, so she's not. So I can say, wow, that's so silly. Just because of your religion, you're not gonna get a blood transfusion. That is not what I do. As a nurse, I do not judge. It's not my decision to make. It's the patient's, and I stick by their decision even if I don't agree with it. I knew that if this woman got a blood transfusion, she would live to probably meet her grandkids. And I also knew that if she chose not to get this blood transfusion, she would not live. So with that, it's again not my decision, and I don't judge. I educate the patient and very clearly say, and the doctor does this as well. If you don't get this, there is a very likely chance you will not survive this. But in the end, it's their choice after I've educated, and I have to do that. So I'm also going to be an advocate. Unfortunately, the doctor that day, or I guess that was assigned to this patient, was not very nice to her about this and kind of treated her as if she was stupid for not making the decision to get a blood transfusion. But that is not our goal in healthcare. We are supposed to be there for people no matter what their decision is. Even if we disagree with it, we are supposed to be with them. So this patient, unfortunately, chose not to get blood products, and I never got follow-up because it was, several weeks later before I was back on that unit again. So I don't know if she made it or not, but because of her religion and those things, I think she did choose to follow through and not get that blood transfusion. And with that, maybe she didn't make it. But that's her religion, that's her choice. So as a nurse, I also don't judge. I advocate for the patient. And I'm there for them regardless. So not just a nurse, you become kind of like a friend during this too. Also, another patient I had during my clinicals and med-surg was this mother, and she had brain cancer. She had 3 or 4 kids, I can't remember, but they were all under the age of 10 or so. But I remember this day I went in, we were receiving a report from the night shift nurse on the floor, and we had gotten a report, hey, she had this scan yesterday, she's supposed to get the results this morning. So anyways, after the day kind of went on, the doctor came up and said, hey, you guys, you're taking care of room, whatever it was. She has brain cancer. We're like, okay, this is so horrible, and, but let's, can't she get treatment? And we're asking these questions as the nurses. And the doctor goes, no, it is stage 4. She is not going to do anything and probably has a month to live. That's a lot to take, right? Like, not everybody hears that every day. That's not someone's normal work day. So with that, we were like, okay, when are you going to go talk to her? We'd like to be with you. He said, well, I'm actually not the one that will be, telling her this news. The oncologist, which is like the cancer doctor, so to speak, is going to be the one to share this information. So we're like, okay, when is he going to be there? Well, he can't be here till tomorrow. Okay, so if you think about this now, here's a scenario. I'm a new nursing student. This is, only my second day at clinical. I'm with the nurse. And we know this about this lady, that she has brain cancer. She has a husband and 4 kids under the age of 10. And we have to treat her no differently the whole day, because we still have the whole rest of our shift to care for this woman. And we can't tell her that she has brain cancer, but we know she does. So in a sense, sometimes as a nurse, you're kind of an actor too, so to speak. So that was a really tough day, going into this room, giving this lady these medications, telling her what's going on, knowing that she has brain cancer and a month to live, and not even she knows that, or her husband, or her kids. So sometimes you're kind of like a little secret holder too as a nurse, but it's also a privilege to be a part of that patient's life. And I also knew, so the way I took this is that I get to be the person that can give her one last normal day before she finds out she has brain cancer tomorrow. So you also have that privilege. So you can take it and turn it any way which you want to. So I decided, I'm going to have fun with her today. I'm going to try and make her feel as good as she can, because I know what she's going to hear tomorrow. So that's also, you're never just a nurse. I kind of felt like family that day for this patient. So moving on from that, I also, during my med-surg clinical, got to go down to the emergency department for a shift. And this is actually where I fell in love with the ER. Everything's very fast-paced. You don't know what's coming in. It's busy. Sometimes it's not. Things walk in, people that walk in, super sick, and then something happens to them, or you have ambulances coming in, bringing patients. Very fast-paced environment. You have to be quick on your feet. And kind of be good with your skills, because you might have to do one any minute. So for instance, what kind of drew me to the emergency department most is I was down there for maybe like 15 minutes. It was just the start of the day. And we had this person come into the triage area, which is where you check in the ER, and they triage you, meaning they sign you an acuity level, which means you get a 1, 2, 3, 4, or 5. 1 means if you're assigned to 1, you're either dead or you're dying. 2 means, oh, this person maybe has 30 minutes before, something really bad happens. 3 is like someone who has like a urinary tract infection, they have a fever, their heart rate's high, they need IV antibiotics and a bunch of blood tests, scans. That would be like someone who's assigned a 3. 4 is like you broke your arm and we need to put it in a cast. And 5 is like maybe you cut your finger and need some stitches. So this person checked in at the triage center and said they had chest pain. So you're like, oh no, so what are you thinking is happening? So this patient, you're like, if they have chest pain, maybe we have to think about a heart attack. So we call that in the hospital setting an MI, or a myocardial infarction, MI. So also during med-surg, you learn these terms so that when you actually get out to the clinical setting, you know what they mean. So myo means muscle, cardial means cardiac, so heart. So myocardial, muscle of the heart, and then infarction means like death. So muscle, so cardiac muscle death. So what happens in a heart attack is somehow a blood clot or a piece of plaque from the veins builds up and gets lodged in one of the arteries that feeds our heart blood. And when it blocks that, blood can't get past that section of the heart. So what is it that blood has that's so important to sustain life? Oxygen. The point of our blood is that it carries many other things, but most importantly, oxygen. So what happens in a heart attack is that plaque or that blood clot gets stuck in one of the arteries that gives the heart blood so that it can continue to pump. Is it gets stuck, and then blood cannot move past that point. So that means anywhere below that blood clot or plaque, oxygen is not getting to. And in order for cells to work, we need oxygen. So if cells aren't getting oxygen, what happens? They start to die. So that is the infarction. Infarction means like cell death. MI, or a heart attack, is a infarction or death of the muscle of the cardiac, or the heart. So with that, this guy comes in and says he has chest pain. So the first thing you think of is, oh, are they having a heart attack or an MI? So we do something, we put something on them called an EKG. So it's these stickers that go on and we hook it up to these electrodes and it measures and it shows us what their heart looks like. So that, for instance, is a nursing skill you would learn during your skills lab, how to do an EKG. So in an EKG, you see these particular waves. So it's kind of like the heartbeat. And if someone is having a heart attack, sometimes they can have this one, I guess, hump, you say, that looks extra, extra high. So we hook this guy up to the EKG, and sure enough, he has a totally like this huge hump where there shouldn't be one on his EKG. So with that, we have to fix him, right? So someone's having a heart attack or an MI, what do we do? So this is where nurses come in. So what we're gonna do is we're gonna give him aspirin to chew. So aspirin, that helps keep the blood clot or plaque from actually getting bigger. So we're gonna give them aspirin and make them chew them. We're gonna hook them up to the cardiac monitor because what can happen if cells in the heart are starting to die? Well, their heart could stop. So we need to make sure that we are monitoring them so we can see if and when that's gonna happen. So we've hooked them up on the monitor. We're also gonna give them oxygen. So what little blood they have kind of going through their heart, we wanna make sure it's fully oxygenated. So we're gonna put them on some oxygen. And then what they do for heart attacks is they actually insert a catheter. It's this little tube, I guess you could call it, and they insert it either through your radial artery, so that's where you can like feel your pulse, or your femoral artery, which is kind of right next to your groin, and you can actually feel it pulsating if you were to like feel your wrist right now. So what we have to do is we have to take him, once we do all those other things, so hook him up to the monitor, give him the aspirin to chew. If their pain is too high, we'll also give them morphine usually, because it helps open up those vessels in the heart, and maybe that will help dislodge that clot so then blood can get around it. Is we take them to the cath lab. So it's called a catheter, but it's really just this tube. So our goal is to get this done as soon as we can, because the longer that clot's in the heart, the more heart cells are dying. So we get them to the cath lab and they insert this catheter through their radial artery. They usually try first, and they insert it, and they actually insert it all the way to the heart. And then they get to right where that blood clot is, and this thing almost sucks that clot or that piece of plaque out, and then we restore the blood flow to the rest of the heart. So the goal for this to happen in most places, kind of the standard practice of care, is when someone comes in and they say they have chest pain and we recognize they're having a heart attack or an MI, is we want to get them to the cath lab within 60 minutes. That seems like kind of a long time, but when you're doing all this stuff, that time really goes by fast. So in this case, we have this guy come in, he's having a heart attack, we're giving him aspirin to chew, we're giving him morphine, which is a pain medicine through his IV. So we can help with that chest pain, and maybe it opens up those blood vessels in his heart so the plaque can kind of go through. And we also have to get an IV started. So it was so busy, and I happened to be in the room when this guy came in. So a nurse hands me the IV start kit and says, "Here, can you start this?" I'm like, oh my gosh, this is my time. So I say, yes, I can. So I'm doing this for the first time. It's not actually on a mannequin. So I get this guy's IV started and I do it perfectly. I'm calm. I don't miss it. It's flawless. And at that point, I knew the ER was for me. So once I get that IV started and we have him on the monitor, now we got to rush down to the cath lab so he can get that thing inserted so we can remove the plaque or the blood clot from his heart. So we go there. He gets on the table, they insert that thing, and it was the fastest time the hospital had had yet. So it actually took us 14 minutes from the time this gentleman came in to the time we had that catheter inserted in the cath lab. And a lot of that, I do have to say, is because of how quickly the nurses reacted and how quickly we got things done, like had him chew aspirin, how quickly we did that EKG and knew to do it. So there wasn't a doctor there that said, hey, you need to do an EKG, he's having chest pain. We knew that because that's what we were taught to do. We need to start the IV so we can give them these medications. We knew that. So that was nursing interventions that were happening. And it was nurses getting them to the cath lab, things like that. So nurses play such a huge role in patient survival rates. and how well patients do in the hospital, because we're with them the most, and we really treat and recognize those signs and symptoms patients are having. So that's when I found my love for the emergency department. So that was kind of my story that got me interested in that. So next, after your med-surg semester, you go into labor and delivery and pediatrics. So you get to help bring life into the world, and then you get to clean it. So this is one of my favorite semesters. I was lucky enough to be at Children's Hospital of Colorado. Their big campus is in Aurora, and I really got to meet so many great people and nurses, and be with the kids. And as tragic as it is for some of the kids, what they're in there for, it's such an honor to be a part of their life. So really great. So back to labor and delivery. So with this, I also had a thought when I first entered nursing school. I thought maybe I could be a labor and delivery nurse. So you actually help women when they're pregnant give birth. So you're there for the whole thing. You give them medications, you tell them when to push, you work with the doctor to help deliver a baby. So that's pretty cool. So my first day on the labor and delivery floor, I actually saw, it was either 5 or 6 births that day. I saw both vaginal births, and I saw C-sections. So even just asking you guys, how many of you guys have seen a baby been born? Not very many. How many people have seen more than one born in a day? Well, me as a nurse, I get to say I saw 6 babies get born in one day, and not everybody gets to say that. It's such an honor. So, you're not just a nurse. I got to see all those things in just one day. So really quite incredible. I did learn through that, though, that maybe, that part wasn't for me. I didn't really like the screaming moms, but some people love it. So it just depends. I did, however, love pediatrics. So I was at Children's Hospital, like I said, and I had some, pretty rough cases there. So I'll start with one. One of the first cases I had on my first day of clinical there was this patient. She was 16 years old, and she had 2 younger brothers. And she was out driving one night. Her mom was at work, and she was driving with one of her brothers, the youngest brother, to go pick the middle brother up from like soccer practice or whatever it was. So she goes to pick him up, and on their way home, it starts raining really bad. She ends up losing control of the car, and they flipped and spun around, and it was a very, very bad car accident. So her leg got split open. One of the brothers ended up breaking one of his femurs, which is the top part of your leg, and that bone is very, very difficult to break. And he had internal bleeding. She ended up having a very bad concussion. But during this horrible car accident, the youngest one that was in the back actually did not survive. He died on scene. So what happens in this case and scenario, someone calls 911, right, and an ambulance shows up. Well, once the ambulance shows up and gets those people, or these kids, they call Children's Hospital and say, hey, we're coming in, we have 2 kids, one's 16, one's 10, and they were just in a bad car accident, and they tell them, what they see so far, like, this kid and looks like he broke his leg, she split her leg open and is bleeding. So they call, and guess who picks up the phone when they call? The ambulances do. The nurse does. So in the emergency department, we have something called like a biophone. So once it rings, you have to pick it up. So the nurse picks it up and answers this call from the ambulance saying, hey, this really, these 2 kids that were in a bad car wreck are coming in. So the nurse says, okay, they get the rooms ready, they make sure the doctors are of them, they make sure there's enough nurses, and they alert the emergency department that, this is coming in 5 minutes. So anyways, these ambulances show up that have these 2 kids in it, so the 16-year-old and then her middle brother that was 10. And of course, as I stated earlier, the youngest one, did pass away on scene. And the woman that receives these kids, and it's her room when they get rolled in to the room by the ambulance, it's actually their mom. So she was a nurse in the emergency department at Children's Hospital. And when she was getting a report from the ambulance about these 2 kids coming in after a horrible accident, she had no idea that it would be her own. So just think about how tragic that is. So anyways, once the kids get out of the ER and they have to come and stay up on one of the med surg floors for a few weeks, just because they were so sick and broke so many bones and concussions and whatnot. So I ended up getting her to care for actually a couple weeks in a row. I took care of her. And this was not an easy patient to care for. So imagine, being a nursing student, going to clinical and walking into this girl's room, and she was 16 years old, and, saying, "Hey, my name is Morgan. I'm going to be your nurse this weekend. I'm a nursing student." She was just very flat, very depressed. But honestly, who wouldn't be, especially if you were the one driving, whether it was your fault or not, and one of your brothers, not living through the accident? You would feel horrible about that. So I had to care for this patient, and it was very hard to maneuver. She was not friendly with me, wouldn't really answer my questions, very stone cold and stoic. Just really was not interested in life at this point. So I kind of had to figure out, as a nurse, how am I going to break the seal? How am I going to get this girl to talk to me so she can, talk about what's going on? You can't just keep this in. So throughout this and my time caring for her as a nursing student, I became this girl's best friend. Something I found out is that she was a cheerleader, and her mom approached me and said, "Hey, would it be okay if her, all of her friends in the cheerleading squad would come surprise her?" So I was a part of setting that up when, her cheer team would come and surprise her in the hospital. So you're not just a nurse when you're caring for these people. I ended up getting a really good connection with this girl, and she opened up to me about what happened. We were able to get her help, and she ended up talking to me a lot about her feelings and, everything after this accident, since she felt so horrible and guilty about it. So where I'm going with this is, you're not just a nurse. At the end of the day, on that day, I ended up being her friend. So you're more than just, starting catheters, starting IVs, giving medication. You're much more than that when you're a nurse. Something else, another very difficult case I had at Children's Hospital. So many times at Children's Hospital, they see patients who are from abuse cases, whether it's, whatever the abuse is. So in this case, I had this patient. It was a 9-month-old, I believe, 6 or 9-month-old baby, and his eyes were bloodshot red. He had blood basically pooled in his eyes. He he couldn't really see, so like he'd wave his hand in front of his face and he wouldn't like see it. He also had a little bit of blood around his ears and bruising. He had bruising behind his ear. He had a bruise around his ankle, and bruising around his, like, right underneath his nipples, right around his rib cage. So if you kind of think about that for a second, knowing this is abuse case, what do you think happened? So just think about that for a second. Bruises behind his ears, he had blood in his eyes, bruising around his rib cage, right underneath his nipples, and then a bruise around his ankle. What do we think happened? So in this case, unfortunately, it was shaken baby. So whoever it was, mom or dad or different caregiver, they had shook this baby. So grabbed him around the rib cage, shaken him. They had shaken him so hard that his blood vessels in his eyes broke, and it broke other blood vessels in his head. And so he did have a little bit of blood in his ears, and that's why he had bruising behind his ears. He also had the bruise around his ankle because he was thrown down by someone holding his ankle. So very horrible. So with that, I was, totally intimidated to take care of this baby. But what do all babies do? They eat, they play, they sleep, and they poop, right? So throughout my day, I would have to feed him, every so hours. I would have to change him every so hours. When he woke up, I'd play with him every so hours. I would care for him. And I realized that day that I was actually kind of a mom. So again, going back to that point, you're never just a nurse. So this particular day, as a nursing student, I was taking the role of a mother or a parent or a caregiver. I was feeding him. I was playing with him. I was changing him. I was snuggling him. I would rock him to sleep. And not everybody gets to say they do that. It was quite an honor, and I felt so horrible what had happened to this baby. But as a nurse, all you can do is be there and love them and care for them as much as you can. So slowly throughout nursing school, I started to realize, it's not just nursing. You're so many things. You're a friend to that 16-year-old that, thinks she killed her brother in this car accident. You're this baby's mother for the day when you're there caring for them. At Jehovah's Witness, I was their advocate when she said, no, I don't want blood. So I make sure, the doctor knows she does not want blood. So you're so many things. So moving on, sometimes there's some extra opportunities because you have a summer off during nursing school. So I ended up doing an internship. And I was on float pool. So that means you go to all those floors. So I went to that med surg floor. I went to that tele floor where they have cardiac patients or heart patients. So those are like where people go after they have a heart attack. I was on the trauma floor where people go after they, have a bad car accident or a motorcycle accident or something. So I got this internship. I did it for 10 weeks, and it was the best thing I could have done. It got me so much experience. That is actually a picture of the dog. It was the floors, all of the floors therapy dog. Her name was Gracie, and she is a Newfoundland. She is huge. So she was always just so fun, and then we could wheel her right up to the patient's bed. So really, really cool and unique experiences. So during this time, I actually was lucky enough to go on an ambulance ride along, and I was interested in that, because I had fallen in love with the ER during my time doing that. So this is the back of the ambulance, but I want to tell you about an opportunity I had that came up with this. So I was with the ambulance for a 12-hour long shift. That's usually what shifts are when you work in the hospital and whatnot. So it was towards the end, not a whole lot of exciting stuff happened, but, I still got to see a lot. Right towards the end of the shift, we had about 2 hours left, I think, so we were 10 hours in. We get this call. So I don't know if any of you have been up to Horsetooth Reservoir up in Fort Collins, but that's where I was at doing this ride along since I was going to school up at the University of Northern Colorado in Greeley. So anyways, we're in this ambulance and so someone calls 911 and it goes to dispatch. And dispatch then has to find an ambulance crew that's nearby and say, hey, you need to go help these people. So dispatch calls us and say, hi, apparently this gentleman was in a biking accident. He was riding his bike and was going down one of the hills and just fell all of a sudden. And the bystanders are on the phone right now and they're with him. And, usually they stay on the phone with them until, the ambulance gets there. So we're like, okay, we'll go up to this call. So, and it was kind of a long drive because we had to drive through the little parts to get up to this one particular kind of road trail that this gentleman was on. So as we're riding up there, the dispatch then gets updates from the people that are with this cyclist and they say, oh, he stopped breathing. So now the dispatch person tells them, okay, give him breaths, check his pulse, and then they're like, he does not have a pulse. So what do you do next? You start CPR or chest compressions. So once the dispatch found this out, they tell us this so we can start to get stuff prepared in the back of the ambulance. So they say, hey, he lost a pulse. Bystanders that are on the phone have started CPR. So we get up there and these bystanders are doing CPR. And as a nursing student, you can still do a lot, but sometimes you can't always administer medication in these kind of fast-paced scenarios. So I knew that the EMTs and the paramedic I was with needed to give my medications and intubate this person. So that means put a tube down their throat into their lungs. So then you attach a bag to it and then you breathe for them. So I knew they had to do those things. So in order to relieve these people, because they had been doing CPR for 15 minutes trading off, I did CPR. So I got down. This was my first time doing CPR. It was, I think, close to 101 degrees that day, up on there. So I start doing CPR. It was my first time, which is very bizarre experience if you've never had to do that. You're basically in between life and death at that point. You are making someone's heart beat for them. So that was my first time doing deep CPR. And we ended up working on this gentleman, or doing CPR, for about an hour. So what they decided to do, since it was such a long drive up into Horsetooth Reservoir, is they ended up calling Flight for Life. And that is the helicopters you'll sometimes see. And so they actually landed down on the mountain and got him. So we're doing CPR. So it was still going to be about 15 minutes till Flight for Life got there. So we're giving this guy medications to try and get his heart beating again. They've intubated him, where they've put that tube down his throat into his lungs so they can breathe for him. We're doing everything we can. And so it's just the three of us working together. So we're all switching off between doing CPR. So then when it gets to my turn, it had been about 15 minutes we had been doing CPR, and the paramedic goes, "Nothing is working, maybe it's time to call it." And I'm thinking about this as I'm doing CPR, chest compressions on this guy. If they call it, I would be the one that would officially, his heart would stop. So that's kind of crazy too. Not everybody says that. So I was very, I guess, terrified in that moment that they were going to call this gentleman's time of death, and I would be the last one to have, made his heart beat. So with that, we decided to keep going because we found out that Flight for Life was actually landing. So he landed, we continued to do CPR, handed off the patient to the Flight for Life crew, and that's usually a nurse and a paramedic on the helicopter, and then of course the pilot. So we give them a report, tell them everything we've done, and they continue CPR up in the helicopter and take him to the nearest, hospital. So to this day, I do not know if this gentleman made it or not. So that's something too that's really a hard struggle for nursing, especially in the ER, as you see these patients, and sometimes you never know what ends up happening to them, especially if your shift is over or you have to take them somewhere else, like the cath lab. Sometimes you don't always get that follow-up. But that was my first experience doing CPR. And as annoying as it is sometimes that even your teachers have to do it, or depending on what your parents or guardians do for a job, you have to take the CPR class. But really it is important, because you never know when you're going to be in a scenario where you have to do it. And honestly, wouldn't you rather know how to do it than not? So always take that stuff seriously. So moving on, my summer was over, and it was time to do my last 2 semesters of nursing school. So they kind of combine this one, so it's psych and public health. So psychiatric, you learn about all these different mental health illnesses that people have, and it's really a plethora of things that you can see. During my clinical at one point, this lady very much thought that she was married to George Clooney. I don't blame her, but she truly believed this. And she was like, "Oh yeah, we own this house on an island together." And they just have these things that they truly believe in their heart are real. This is the case for people who have like hallucinations, or are depressed. There's something going on. Usually it's chemical imbalances and sometimes we can help with that with medications or therapy or whatever it is. We always try and do therapy over medications so someone doesn't have to rely on those. But sometimes it's a combination of both. So I didn't love my psychiatric clinical. I realized it wasn't totally for me, but I did learn so much. And then you have public health. So I was like, oh, this is going to be boring. It is actually quite interesting. So they actually, speaking of which right now, they plan for things like if there's a pandemic in your town, if there's a tornado that tears all these houses, they help say, oh, well, this is the hotel that people will stay at. This is, we can give food at this elementary school and tell people to check in. Or let's say there's a rabies outbreak. So someone got bit by a bat and now they have rabies and they've given it to other people. They help handle those situations that are within that community. So for instance, let's say for some reason, let's talk about New York with COVID-19. Um, so let's say there are too many people that are sick and there's not enough beds in a hospital. Where would you put those patients? You can't just leave them on the street, and you need to care for them. What are you going to do to help care for these patients? Where are you going to take these patients? So usually in a live class, I would ask everybody this. So I'll give you some answers I've received in the past. So one of them was a school. Okay, are there beds in a school? No, there's not. So you're going to have patients lay on the ground? I guess if you had to, is there enough sinks? Is there enough bathrooms? Is there, you have to go through all these things. How big are schools really? Well, someone said a stadium. Well, that sounds quite cold, right? And there's no beds. You're going to be sitting up in a chair. So those are usually the two most popular ones I get. And I didn't even think about this. So what they do in a situation where hospitals are overwhelmed is they actually can overtake nearby hotels and turn them into hospitals. There's beds, there's laundry so you can get linens done. There's that main desk at the lobby so you can treat that as a nurse's station. I mean, it just works out perfectly. There's a bathroom in each room. You don't have to build anything or do anything. You can just take a nearby hospital and utilize it, or a nearby hotel and use it as a hospital. So they come up with stuff like this. So something else to think about that actually did recently happen in New York when they were booming with COVID is you have all these people dying, whether it was from COVID or not, because you still have regular death on top of COVID death during a pandemic. People still die of heart attacks. People still die of strokes. You have all those things. So you're going to overrun the morgues. A morgue is where someone's body is kept. So with that, what if, usually a town in a place like, for instance, in Parker, I think the morgue holds like 10 or 12 bed spaces. Like there's really not that many dead people at once, as horrible as that sounds. So what are you going to do if all of that morgue space is full? Right? So I usually ask this question in live class again. Usually the responses I get, well, why don't you do a stadium? Okay, well, what if it's summertime and it's hot and now all this disease is going around and there's just these dead bodies stacked at mile high? That's not really going to be safe and it's going to start smelling. There's things like that. So what are you going to do? So you actually, public health nurses have the ability to overtake refrigerator trucks, so like Pepsi, Coke, or Coors Light trucks, and stack bodies in them. It not only fits them, it will fit many of them, you can stack them, and it's refrigerated, so it prevents the disease from spreading, or it should, but you can keep them in there until you have more space or figure out what to do next. So that is something that we actually saw that I never would have thought in a million years would happen, but thank goodness for public health nurses because they help set these things up. Quite incredible. So again, still going on that topic, what if the morgue's full and we have all these trucks, but there's not enough trucks either? What are we going to do with these bodies until we can bury them? Where can we put them? So not a stadium. Let's say we don't have any more refrigerated trucks. In the state of Colorado, what the plan is they'd actually overtake ice rinks and they would start to stack the bodies in ice rinks. It's cold, right? And you can stack them, and it's a closed space, so no risk of the disease coming out. So they plan all this. So as boring as public health sounds, they actually do a lot of pre-planning, especially for disasters or pandemics like what we're living through now. They help choose, mask protocols, for instance, like, no liquor sales after 10, like all these things, there's a reason behind them. So really quite interesting. And a lot of that is dictated by other people, but public health nurses in those communities take a huge role in that. So moving on to fifth semester, that's like your last semester of nursing school. You kind of learn and review everything you've learned, but you also get placed in a hospital for majority of the semester and get paired with a nurse. So this is the one I was paired with. Mandy was her name, and I worked with her at St. Joe's Hospital. That's right in the heart of Denver, and I was lucky enough to get placed in the ER. I had told them I was interested in it, and they knew I took it seriously, so I was lucky enough to get my preceptorship, it's called, in the ER. And you do it for like 16 weeks, I believe, is how long the preceptorship is. So you go to clinical, and like I said, I've always learned the most in clinical. I got to start IVs, I got to do catheters, CPR, I got to do all those things and learn them. I have this disease in front of me, or what do I think this person is coming into the ER for, and what am I going to do for him? So I got to really put all of that into action before I go out into the world and become a real nurse, so to speak. So with that, I want to talk about some scenarios that were really important to me when I was in nursing school doing my preceptorship at St. Joe's in their ER. So my very first day, I have this gentleman come in, and he's complaining of being constipated. So I'm like, awesome. I was really hoping like, something would come in, not for their sake, but, a heart attack or stroke. I really wanted someone who's really sick to come in, because, you do learn a lot in those situations. So I get there, and they're like, yeah, this guy has constipation. He said he hasn't pooped in 2 weeks. I'm like, oh my gosh. Okay. So I go in, and part of nurses is you do your head to toe assessment just to make sure everything's regular. So I do my head to toe assessment. I'm talking about, well, when did you last have a bowel movement? Blah, blah, blah. What medications have you taken? And as I'm listening to his lungs, I see this bruising on his lung. Oh, that's strange. So I kind of asked him about it. I said, hey, where'd you get this bruise from? He goes, well, I fell in the shower. Well, when did you fall? About 3 days ago. Oh my goodness, does it hurt? And I touched it, and he, about jumped out of the bed. And then I noticed, like, oh, he kind of seems like he's breathing fast. Hey, are you short of breath? Like, do you feel like you can't catch your breath? He goes, yeah. Well, have you felt like that since you fell? Yeah, it seems to be getting worse too. So I'm like, oh my goodness. So the nurse, once I'm done doing my assessment, I go and tell the doctor, like, hey, this gentleman's here for this. He's this years old. He's, taking these medications at home. He hasn't, but during my assessment, I noticed that he has this bruise on his left side, or whatever it is, and tell him all of my findings. So it turns out, because I did my full assessment, sometimes the doctors look or don't look, especially ER doctors. Sometimes it's such a fast-paced environment that they just focus on what the patient's there for, and they don't always do that head-to-toe assessment. They should, but doesn't always happen. We don't live in a perfect world. So I told this doctor this. He ended up, looking. We ended up doing an x-ray, and this gentleman had fallen in the shower and broken almost half his ribs on that side. And the rib was close to puncturing one of his ribs, and if it had, it kept going in and in and in, because we hadn't, hadn't been seen or bandaged for this at all. So his rib was pressing on his lung. It had not quite punctured it yet, but if it were to, he probably would have lost his life, because he would have fallen asleep or something just because he felt tired. So because I did my full assessment, I potentially could have saved this man's life. So I was so bummed that this guy came in for constipated, but really you never know what's going to happen, or how someone's condition can change while they're in the hospital with you. So as much as I was bummed that it was constipation, I ended up potentially saving this man's life just because I was thorough and did my full assessment. And I'm still in nursing school. So quite cool to say that. Not everyone gets to say that, but a nurse does. Next, I had this gentleman come in. He had lug wigs. So not many people have heard of that, but it's actually where you have the abscess in your mouth. It starts with a tooth and then just gets bigger and bigger and bigger. And it actually has pus in it. It's called an abscess. So what they do is they cut it, and then they drain out that abscess. So this gentleman had a very bad abscess on one of his back molars and was starting to go into his throat. So what is something we would worry about if this abscess or this swollen area is back in his throat? Well, we worry about his throat closing up. And if your throat closes, what can't you do? You can't breathe. If you can't breathe, you can't get oxygen. If you don't have oxygen, you can't get that in the blood and give all of your body the oxygen it needs in order to survive. So this gentleman came in. He said, my mouth really hurts, and he knew he had this. He just didn't do anything about it. And he's like, it's getting bigger and bigger, and I feel like I'm having a hard time breathing. So he's sitting on the bed, and me and the doctor are looking at it. And all of a sudden, he just kind of turns pale and says, he looks at us in the eye and goes, "I'm going to die. I'm going to die. I'm going to die." And guess what? His eyes rolled back in the back of his head. He stopped breathing, and he ended up losing his pulse. So who would have thought, because someone came in because their mouth hurt, that they would be on the bed 5 minutes later and that I would be doing CPR on them. So I start CPR on this guy. We end up barely getting him intubated. So again, that's when that it's usually the doctor who does this. Nurses are not trained on this, but they put a tube down their throat into their lungs. And because there was so much swelling and his throat had almost closed up all the way, that's why he's, stopped breathing, and then his heart stopped. We almost couldn't get this tube in. So luckily we ended up getting this tube in, and we kept working on this guy. So we did CPR on him for about 25 minutes. We shocked him, all of that. But because of our quick, thinking and starting CPR right away, this man we were able to get him back, and he lived and went to the ICU. But again, this is what I'm trying to get a point on. You never know what someone's going to come in with and how it changes, especially while they're in the ER or even up on the nursing floor, anything, or even go to a doctor's office. You never know what's going to happen. So quite an honor to be a part of those situations and, be a part of saving someone's life at the end of the day. Also in the ER, you can have really happy things and really sad things. So one particular day, I had a lady that had been trying for years and years and years to have a baby and had in vitro, which is where they basically manually fertilize the egg, so then that mother can have a baby. So it's not natural the way they fertilize that egg. So one lady was having a miscarriage that had tried so hard. She was absolutely heartbroken. And someone came in that day that also happened to give birth in the ER. So in the same day, you can have these two very opposite situations happen. You can see life and you can see death. And not everyone gets to see that, but a nurse does. So you're never just a nurse in this scenario. So finally, after you finish your preceptor SIP and everything, you get to graduate. So I have my nursing cap on there that says, because even doctors need heroes. So even if a doctor were to have a stroke or a heart attack, guess who would be there giving them that aspirin, suctioning, doing chest compressions. It's going to be that nurse. So quite an honor. So that's all I mean by that. There are many of my close friends in those photos, and that is my mom actually placing my nursing pin, which is a really exciting moment at the end of nursing school. You invite the most important people in your life up onto the stage, and they actually put your nursing pin that you've worked very hard for up on your shoulder there. So quite an honor. So I did get through nursing school. It's hard, but very much so worth it. Best decision I've ever made. After you're done with nursing school, you're not actually done yet. You have to take something called an NCLEX. So it's a standardized exam, and this is what actually gives you your certification that you're a registered nurse, that you have your bachelor's in nursing. So even though you graduate from nursing school and get your diploma, you have to get this in order to get your nursing license, and you cannot get a job without your nursing license. So the NCLEX, a really good way to explain this is where every answer is right, but only one answer is more right than the others. So for instance, it would have a question about someone having a seizure, and so it'd say, what would you do if someone's having a seizure? So one of the answers is, oh, well, turn them on their side. Second one is give them oxygen. Third one's give them the medication to stop it. Fourth one is get the provider. So in that instance, all of those answers are right. Which one's most right? Technically, the most right one is you're going to turn them on your side first. Then you're going to call for help. Then, your help's going to come. Someone's going to get their airway, manage the airway, so to speak, give them that oxygen. Someone's going to be suctioning, and someone's going to be giving them that medication. But technically, that answer there would be that you're going to turn them on their side, because you worry about aspiration, which is, again, when you inhale and then it gets into your lungs. So for instance, if you've ever swallowed down the wrong pipe, that's what it's kind of referring to, where you kind of can't catch your breath for a minute. So you want to prevent that in a seizure. So that is what the NCLEX exam is like. And it takes several days or weeks even to get your results. Once you pass that, then you officially have your nursing license and can start your job. So as I said, I had my last semester of nursing school at St. Joe's in their ER, and I was lucky enough, I actually created a job for myself, and I was their first new grad nurse at St. Joe's in their ER. So I created a job for myself and started working here out of nursing school. So I want to talk about my first code blue as a new nurse. So as a new nurse, there's lots of anxiety around it, lots of excitement, just because you're like, oh, I finally got out of school, I'm a real nurse, and I get to take care of patients. So one of the hardest shifts I ever had in my life, we ended up getting this gentleman. He was flown in on a helicopter, you know, for whatever reasons, but what happened was they were doing CPR in the helicopter, brought him into the room, and we ended up getting him back. So we shocked him and were able to get a heart rate back. We realized he was actually having an MI or a heart attack. And so what do we do next? We want to take him to the cath lab, because they insert that catheter and remove that plaque or that blood clot, whatever it is, they remove that. So that was our goal once we got him back to life. And how did we figure out he was having a heart attack? We put him on that EKG machine, and then we saw that really big hump, and we're like, okay, he's having a heart attack. So we got him back after doing CPR and giving him medications. We realized he was having a heart attack, so now we have to take him to the cath lab. So in St. Joe's, they have a very poor design, but their cath lab is on the second floor, so you have to take the elevators up to the second floor. So it's myself, one other nurse, and a EMT. Usually EMTs work in an ER. So we get to the elevator, we have everything we need, we have all the medications we need, just in case his heart were to stop again. And this is night shift, so there's much less resources or help just because of it being nights alone. So anyways, we get on the elevator, everything's fine. We go up to the second floor, we're coming off the elevator, and all of a sudden I hear the monitor. It's just, I see a flat line. Oh gosh. So what do? You check for a pulse, you see for breathing. He is not doing either. So what do we do if someone doesn't have a heartbeat? We start CPR and do chest compressions. Well, again, there's only 3 of us. One of the EMT is pushing the code cart, it's called. So that's where all of our medications are, and that monitor that tells us his heart stopped. And the monitors on there that can also shock somebody. So the EMT is pushing that code cart, and then the other nurse that was with me, he's pushing the bed. And then there's me, right? So what do I have to do? Well, I get on top of him, I do CPR, but what's our goal still? How are we going to save this guy? We're going to save him by removing that blood clot or that piece of plaque from his heart. So we have to go down the hall. I'm doing CPR on this gentleman. We're, trying to get him. We're trying to make it to the cath lab. So the EMT is pushing that cart. The other nurse I'm with is pushing the bed while I'm, straddling this guy on the bed, giving him CPR. So, I guess you could say it's straight out of Grey's Anatomy. I was not prepared for this, but we were as well. I didn't run through the scenario. Well, what if his heart stops after we get out of the elevator? What are we going to do? You don't think of those things, but we did have everything we needed with us. So we ended up getting to the cath lab. I'm still doing CPR. They get them all hooked up and ready for the procedure. And then they do the procedure, and they end up, they remove that piece of plaque or blood clot from his heart, and that blood supply is restored, and I'm still doing CPR, and we're all switching at this point, and we end up getting his heart starts beating again. So again, this is another life we saved. I don't know if he lived many days after that, but I learned so much in this moment that anything can happen. Be prepared for the worst. So in this instance, I should have expected, well, what if he codes in the ER, or, his heart stopped? That's what codes means. So what if his heart stops in the elevator? What am I going to do? So thank goodness I had all my training and I knew what to do. And we were able to save this guy's life. But this was my first shift off of orientation, which is where you're paired with somebody. So this was my first shift off of orientation on my own. So very stressful day, but very rewarding at the end of it. But not everybody gets to say that, but a nurse does. So that day we were able to save a life, myself and my coworkers. So after about 6 or 7 months I was at St. Joe's, I decided to move on to somewhere new. So hospitals are designated trauma levels, and that means like how sick of people can come in if some type of trauma happens, meaning a really bad car accident or a shooting or things like that. So I was at St. Joe's, which was a level 4 trauma, and I moved to Medical Center of Aurora, which is a level 2 trauma. Level 1 is the highest trauma center you can get to, then it's 2, 3, and 4. So I decided to go to a hospital that had a higher level of acuity or trauma level. So I went to their ER as well. So I've had many experiences here. So during my time at the Medical Center of Aurora, that's where I work now. I'm an ER nurse there. I had my first GSW, so that means gunshot wound. So my first GSW, it was a gentleman that was brought in. He was about 70 years old, and he ended up shooting himself in the leg. He was cleaning his gun at home, did not look if it was loaded, and ended up firing it, and it went right through his femoral artery in his leg. So that actually gives you blood supply to your leg. So he shot right through that. When that happened, the paramedics or, the ambulance went and got him from his house, and his wife was actually the one that called the ambulance and said, hey, my husband just accidentally shot himself. So the paramedics get him, and during their ride over to the hospital, this patient had lost so much blood that his heart stopped. So they started doing CPR on him and brought him in doing that. So he got to us. We continued doing CPR on this 70-year-old man, and he just would not stop bleeding out of this, gunshot wound. Every time we pushed down on his chest, he was just bleeding more and more and more. So what actually happens in this scenario is the trauma doctor, that's what is at a level 2 hospital centers. There's a trauma doctor on at all times. The trauma doctor comes into the room, and you would think he would keep doing CPR in this circumstance because their heart stopped, right? But why did their heart stop? Their heart stopped because he was bleeding so much. He had lost so much blood. So really, in order to get his heart started again, you need to stop this bleeding, because that truly is what stopped his heart from beating. So what they did is they cut him from the middle of his chest all the way around to his back, and split his ribs open, and opened up his rib cage on that left side, because that's where your heart is closest to. So they do that, and the surgeon's doing all of this, and I'm handing him stuff as he's doing it. I see him open up the rib cage, and I can see this guy's heart and his lungs right there in this ER room. And he goes and he starts to find the aorta, which is, it's this big artery that branches off of your heart and goes down into your body and spreads off to all these other arteries to give your body the oxygen it needs, which is in the blood. So he goes and finds the artery or the aorta and clamps it off. So he basically, he just puts like a stopper there so that nothing can go past that. Because if no blood goes past that aorta, it's not going to get to the arteries down in the legs, and then he can't bleed out any longer. So he goes in, I see him clamp the aorta, and this guy's still bleeding because there's still blood down there, even though he clamped off the aorta. So now we're giving these medications that we would normally do during the code blue. So like epi, you'll hear that on Grey's Anatomy, give them epi. So we're giving him epi, which is epinephrine. It's an adrenaline drug to hopefully try and get the heart beating again. So we're giving him that, and I all of a sudden see the surgeon stick his hand in this guy's chest and put his hand on his heart, and he starts squeezing this guy's heart. I'm like, oh my gosh, he's massaging his heart right now. He's trying to get it to beat again. And it was, a horrible experience that this happened. But, no, everybody gets to say they're seeing some guy's heart being massaged, every day. So we're massaging this guy's heart. We're giving him all the medications we can. We're giving him blood transfusion, and we work on him for quite a while. So I think it was 45 minutes or so. Unfortunately, we did have to call time of death for this gentleman. He was too old, had lost too much blood, and we just could not get him back. But in traumas, most of the time that people, stop breathing, their heart stops, is because they're losing blood. So you don't actually do CPR. You end up opening their chest, so you can figure out where the bleeding's coming from, clamp that aorta off so that the heart isn't pumping blood out of the bleeding source, which would have been his gunshot wound in this instance. So very sad, but very neat thing to see, especially right in an ER and to help do this. The hard part about this, though, is at some point the wife's going to come in. So my doctor and the self were there and, did have to tell this gentleman's wife that, he didn't make it, and we did everything we could. She's very understanding, most likely because she was there when he did accidentally shoot himself. As the nurse, though, you also have to get everything out of the patient's pockets once they, have passed away. We have to get them to the morgue so their body can be cooled, and everything like that. So I am going through this gentleman's pocket, getting his wallet and things so I can give him to his wife, his watch. So I open up his wallet and there is a veteran's card. He served in the war. I think it was a Marine that he was, and I was so disappointed because he knew better, and probably got cocky about it, that you should, this is just kind of a life lesson, but you should always treat a gun as if it's loaded, because if you don't, then something like this can happen and you can't take it back. This gentleman knew all about gun safety. He was in the war, and he didn't do that, and just that one time he didn't check it and was cleaning it and shot himself. He's gone and will never come back, and we had to tell his wife that that was the last time you saw him. So that was my first gunshot wound, and just kind of a life lesson 101, as far as guns go and gun violence. It's a horrible thing that happened, but there are times, especially in young folks that do sustain gunshot wounds, that we can save them. So it just depends on kind of the scenario, and if they hit anything major when they either accidentally shoot themselves or get shot or whatever the case is. Sometimes we can save people with gunshot wounds. Just a couple weeks ago, I actually had one of my most difficult cases I've ever had. I had an 18-year-old patient come in by ambulance for anaphylaxis. Does anybody know what that is? Sometimes you hear people say like they have to have their EpiPen for them because they're allergic to bees or something. So it's when someone is so allergic to something that their throat will actually close off because it's their body's way of protecting them. So unfortunately, I had this 18-year-old that had recently just moved to Colorado, and she was unfortunately allergic to many things, and she was at work, a new job she started, and started having a reaction, and gave herself this EpiPen and told her manager to call 911. Her manager did not believe her and did not call 911 right away. And because of that, the girl actually did stop breathing at the workplace. Luckily, EMS got there, or the ambulance got there right in time, and were able to start CPR and giving this, 18-year-old breath. We brought her into the ER. We gave her medications. We continued CPR on her for almost an hour and a half. And it was good, but her, luckily the police officers that were on scene were able to call the mother and get a hold of her. So she was in the ER and happened to come in right before we were about to call her daughter's time of death. And in the ER, if family is present, it doesn't happen often. But in the ER, if someone's family is present, we actually invite them into the room to watch us work on them and do CPR is what I mean. So they can actually see that we are doing everything we can to save their loved one. So this was my first time I had ever had family in the room when we were doing CPR on a family member. So we were doing CPR, and of course, the mother is just beside herself, as everyone would be in the situation. And we did have to call time of death with the mother in the room because we could not save this lady's wife. So there's kind of two things I learned in this scenario. One, if someone tells you to call 911, you call 911, you do not hesitate. In this instance, it probably cost this girl's life that her manager did not call 911 when she asked her to. And the other thing I learned is I actually kind of became a loved one this day. her and her daughter had moved out here from somewhere to Colorado, so it was just them. And I was there, when the doctor called time of death, and I was the one that the mom was hugging and holding, and right after this code. So I became a family member, and I was there to be comfort for this woman, after her 18-year-old daughter had just passed away. So you're never just a nurse. Sometimes you become a family member too and are there when people are grieving. Something very exciting happened to me too a couple months ago, and this was actually right during the peak of COVID, was this lady came in, and she's very clearly pregnant, but she came in through triage, which is that entryway where they tell you how sick you are, and all I hear over the announcement is, can I get a nurse and a doctor to room 1? And 5 minutes before that, we had a gunshot wound victim come in. So that, took up a lot of the nurses and doctors. They were in that room, trying to save that person's life. And so I heard this and I knew, I wonder if anybody's going to respond because they're already in this gunshot, GSW room or gunshot wound. So I go to this room and I help get this lady on the bed, and it's just me and the EMT that brought her back. And she's like, the baby's coming out, the baby's coming out. So, I lift up her dress, and sure enough, the baby's head is there. So I get gloves on. And shortly after, the doctor comes in and we actually help deliver this baby. We get the baby out, we put it on her chest, we get warm blankets, and she's like, what is it? What is it? And so I look and I say, oh, it's a boy, so not everybody gets to do that. It was such a special day. It was my first delivery I got to be a part of in the ER. It was just me and the doctor to start. And of course, people rushed in after once they realized what was happening. But really special, not only to help deliver a baby, but to tell, it's a boy, and tell them the gender, but to also be the one that this baby was safely delivered because of my training. So really special day that was. So really quick to talk about COVID-19. Everyone's learning a lot about this, and there's a lot of fear around it, especially when this first started kind of in April is when things started to shut down for Colorado. It was very scary being a nurse at this time. A lot of stuff that you would see on the media would say, you signed up for this, this is what you chose to do. But I did not sign up, to give my life or to do these things. But I did choose to care for them. So what a crazy time it is to be a nurse during a pandemic. So lots of fear around this, even just the way people would treat us. Some would be very kind to us, thanking us for our duty during this time. Others would be upset that we would be complaining about, not having enough personal protective wear is what PPE stands for, equipment. So personal protective equipment. So during this, a lot of what was not shared on media, for instance, is that hospitals were overwhelmed, regardless of the numbers say about it or not, because during this time from usually November to May is the worst season for flu. Many people get hospitalized for the flu, and a lot of people even say, or you'll hear now is, well, more people die from the flu every year than COVID, which is true. So imagine having those patients, people that are there for flu, on top of having people there for COVID. So that is why hospitals were overrun, and that's why PPE was short, because we didn't have enough gowns, we didn't have enough gloves, we didn't have enough goggles or face shields, because in addition to already being usually short every year because of flu season, we were even more short because of COVID on top of that. So I just want to make that clear, and that was my personal experience where I was at, but I know it can differ everywhere. So lots of fear. There was definitely a shortage of PPE. It is much better now. And then my first COVID patient, there's this scenario of this, they have this, and this, but you don't know for sure unless they have a positive test result. So a few days later or a few weeks in this instance, because it had just started, I had found out that this in fact was a COVID patient. But something too, it affects people very different. So I had several people come in that, were just like, oh, I have a stuffy nose, a cough, I'm worried it's COVID. So we test them, they'd have it or they wouldn't. So there was that scenario where people were just fine and had a really, really bad cold, maybe the worst cold of their life. There was other people where it totally rocked their world and they just could not recover. So one of my very first COVID patients was this gentleman. He was in his 20s. He had HIV, or AIDS, so to speak. And that comes with a lot of health risks, I guess, or makes you immunocompromised. So immuno means immune system, compromised means like it's not working as well as you should. So some people have diseases which makes them immunocompromised, where their immune system isn't working. Your immune system's goal is to protect you and keep you safe from doing things. So things that can make people immunocompromised is if they have cancer, if they have like a congenital heart defect, if they have lung problems like asthma. But for this gentleman, he had HIV. So when a patient with HIV, what that is their immune system is being attacked. That's what HIV is. So he did not have an immune system practically at all. And he ended up getting COVID. So during his time in the ER, he had come in, had checked in, was like, I just really don't feel good. He didn't look good either. He had a high respiratory rate, so he was breathing really fast, but he's still like up and talking to me. About 3 hours later, I noticed his oxygen levels kept going lower and lower. So when he came in, he was about 92% on room air. So that means he didn't have any oxygen on. In Colorado, we like people to have an oxygen level of 90% or above. So his was about 92, 93% when he came in. A couple hours later, it was like 89%, then it was 87%. And at that point, you put them on oxygen. And then even on top of him being on oxygen, I had to keep turning it up because he kept getting lower and lower and lower. Finally, he was at about 78%. He was like, I can't breathe. I have the oxygen up as much as I can. And he's like, am I going to be okay? He's asking me this. And everything we were doing, he was just not recovering. He was not getting better. He was getting worse and worse and worse right in front of my eyes. And this was within a matter of hours. Maybe 2 or 3 hours had passed at this point. So finally, I'm talking to the doctor and he decides, I think we need to intubate. So again, they put the tube down someone's throat into their lungs, so then we can breathe for them. We attach it to a bag or a ventilator, which actually breathes for someone. So we decide, I think we need to intubate this gentleman. We have him on as much oxygen as we can. He's breathing fast. And if someone works hard enough, they breathe fast enough, eventually their heart can stop. So that's what we were trying to prevent. So we get him intubated. We get him on a ventilator in about 30 minutes on, maybe it was even 15, 20 minutes of being on a ventilator, his heart stops. So we start doing CPR on him. And with this, because we suspected at this time that he had COVID-19, we have gloves on, one of those paper gowns on, another pair of gloves, so we're double gloved. We have to have a hairnet on with a cap, like a surgical cap. We have 2 different face masks on. So we have an N95, which is like that extra filtered mask. And we have another like surgical mask, which is what you see people wearing now out and about. We have both those on. We have a face shield on. And then we have to do CPR. So just imagine how difficult that is. CPR is very difficult on its own. It's very exhausting as much as it doesn't seem to be, especially when you're doing it on a real person compared to like a mannequin when you do those in classes. So we're all just dripping sweat, it's exhausting. So we work on this gentleman and we got him back. But this happened 3 times where his heart stopped, we got it back, his heart stopped, we got him back. Unfortunately, he did end up passing away in our ER, and that was from 5 hours from when he checked in and I started caring for him. So it really depends on COVID-19, on the person and what their comorbidities or like what illnesses they have, and also if they're immunocompromised, how it can affect them. It's a very real thing, but it does affect things differently, and we're learning more and more as the days go by. So just wanted to share my first COVID experience with you guys is all. And this is a lot of times what it felt like. You were just kind of staring death in the face, especially at first when there wasn't a whole lot we knew about. So this was a picture that someone actually sent to me and said, thank you for your service and everything you're doing. So most of the time I ended up getting positive feedback. And I feel honored to have been a nurse during a pandemic for sure. It's definitely a once in a lifetime experience. So many questions I've gotten every year that I talk at this med class is, so how do you handle all of it at the end of the day? So a lot of my stories, there is death involved, but there's also life involved, or being someone's friend, or, turning into someone's loved one. So oftentimes I get in the car and my steering wheel catches a lot of my tears. It's kind of my release, because sometimes there's just not time at work to have that moment, or you just don't want to have that moment at work with your coworkers. So oftentimes I kind of, let myself experience all the emotions I had that day in my car before I start driving. Also, coworkers are everything. I have a great, group of people I work with, and I, would not be able to make it through the day without them. Journaling really helps, talking about what happened that day and how I feel. Debriefing at work. So after we had that 18-year-old that had that anaphylaxis, and we couldn't get her back, we talked about, well, whose first time was it to have family in the room during this? Well, it was really an honor. I found out that it's actually easier for parents to grieve if they see that the hospital staff is doing everything they can. It actually gives them closure. And then also just time with family and friends, not thinking about work. So there's many different outlets, working out, doing all those things, enjoying time outside. Those will kind of make me handle it at the end of the day. How has being a nurse impacted my life since graduating high school? I'm definitely a better person. I realize how short life can be, but also I get to see the miracles of life every day as well. I have a lot of a, different perspective on life. Live each day till it's the last, because you never know. So I'm very much a positive person, even though, I have really hard days at work sometimes, but you got to make the most of it while you can. And I will always be identified as a nurse. I'm very proud of it. One day, when I have kids and they're at school, I'll be known as the mom that, oh, she's a nurse. At the grocery store, I have my scrubs on. Oh, are you a nurse? Thank you. I mean, people come up to me all the time. So it's truly an honor to be identified as a nurse. For I don't know how many years, I think it's like 20 years in a row, we are one of the most if not the most trusted profession in the United States. Nursing has been voted. The only year we did not get voted for as the most trusted profession was 9/11 firefighters were, which is very understandable. So quite an honor to be a part of this profession. We are truly making a difference. You're seeing people on what could be the worst or the best day of their life. Not everybody gets to say that or be a part of that. And as hard as it can be, it's also very extremely rewarding when you do get that person back after doing CPR for 45 minutes. When someone, thinks they have a really bad urine infection and I've been vomiting for several days, hey, you're pregnant, and they're super excited. When that patient does give birth, or, that patient who's had a migraine for 6 days comes in and we give them medication and they feel better. We are their savior that day. So that's a really great feeling. But again, so we are there for people's worst and possibly their best day of their life. We're the patient advocates. So like I said, with that patient that was the Jehovah's Witness that didn't want blood, I'm the advocate. I'm not going to judge. That's not my job as a nurse. And unfortunately, like I said, that doctor was not very nice and caring after he found out that the patient wasn't going to get a blood transfusion. I was their advocate and said, hey, this isn't something we want to do. They've asked that we not ask them again. We've already educated them on this, and they do not want a blood transfusion. We need to care for them anyways and do whatever we can. So we are their advocate when they cannot be. This is true for people in surgery or coming out of surgery and they're not able to speak for themselves. Patient education. We are the ones that when we discharge someone from the hospital, we give them everything they need to know. So for instance, let's say someone comes into the ER with a broken arm. We're the ones, that say, make sure you don't do this. Don't get your cast wet. Sometimes that's not, common sense to everybody. This is how you're going to take care of your stitches. This is what you need to eat. This is what you need to avoid. We truly help with that patient education, bringing that educational level down to whatever the patient needs. So whatever it is, it makes sense to them. So our goal is to keep them out of the hospital. So nurses are huge on education, and trying to keep people as safe as they can. We're the eyes and ears for the doctor. As I said, nurses are the profession, are most at the bedside the most out of any profession in healthcare. Nurses are at the bedside the most. So we truly are the ears and eyes for the doctors. That doctor would not know that patient was having a seizure if it wasn't for the nurse. So that's truly an honor, and that we get to spend that much time with those patients. There's so many different options for nursing. You can be a nurse practitioner. You can be a surgical nurse. You can actually scrub up in the OR and be an OR nurse. You can work on the cardiac floor. You can be an ER nurse, an ICU nurse. There's even work from home jobs as nurses. There's so many things you can do. It's never ending, which is incredible and so nice, because you're never just stuck doing one thing. What I always say, and I know is very true for Mr. Stirrup and how he feels about teaching, but it's a beautiful thing when a career and a passion come together. And that's exactly what's happened with me and many other nurses I work with. It truly has to be a passion, and it becomes a career, and it's so special to be able to say that, because not everybody gets to say that about their career in life. So I feel so grateful that I found something for myself, and maybe one of you guys today, will look into nursing, and maybe it's the right path for you. So with anything in life, whether it's nursing or not, make sure you choose a career path that you are passionate about, and then you never have to work a day in your life, So thank you for having me again. I think this is number 6 or something like that.
Yeah.
So these are from a couple years ago. And if you have any questions, feel free to email me or whatever you want to do. I'm happy to answer anything. I've had several students ask me where to take CNA classes from, or other colleges I've worked at, or even just questions, about college and how to be successful with that. So that's it.
Oh, you did awesome, my friend. So
Woohoo!
I'm actually going to end this so it starts saving, but I'll give you a call here in about 2 seconds on your cell.
Okay, sounds good.
All right.